May I request the panelist to come on the dais, please? Dr. Anant Ramaswamy, Dr. N.M. Prem, Dr. Rajiv Rajendranath, Dr. Akhil Kapoor, Dr. Agnisha Sharma, Dr. Tarachand Gupta, Dr. Karthik Mittal, Dr. Babita Kataria, Dr. Ani Shrikant Rajamundri. So I think so. What we have a good mix of uh, an oncologist, primarily medical oncologist. Then you have a good mix of geriatrician and occasional pharmacologist. So Akhil, you are required here. So, so I think so. The first question which may come, how do you perceive? Because all of you, I do know that you practice geriatric oncology. That I am aware. Unless someone wants to say that I don't. Uh, I think so. अखिल थोड़ा सा उधर. You want to be seated there? आपको ये light आ रही है आपके चेहरे पे. So, what benefit you perceive when you do this? You perceive the benefit is there or not? I think so. You perceive. That's why all of you practice. But you can say that you perceive or not. And if you perceive, what kind of benefit you think you provide to the patient if it is practiced? Each of you.
It is it makes significant differences in the quality of life, toxicities, and when these are different, the outcomes are also going to be different because the continuation of the treatment, compliance of the treatment depends on these factors. So it is not just adding number to the life, it is about adding the quality of the life for the patients. And that is why when we started at Varanasi with the support, we have gone a long way from just one patient per week to now close to 10 patients per week, and we are going to expand to daily geriatric oncology clinic very shortly.
Okay. So, Karthik.
So thank you, sir, for inviting me
So,
here. And I'll just
Karthik
give.
is a geriatrician
Yeah.
and he works together with oncologists
Yeah,
at Hyderabad.
right. When my medical oncologist, when I met my medical oncologist in the private sector for the first time, he knew about this concept of geriatric assessment and its interventions based on what Dr. Vanita has propagated all over India. So he was like, okay, let's do it, but let's be a bit more skeptical because this is private practice. We are new to it. There is no data in private much out there, so let's be a little bit skeptical. So he just, when all of his investigations and everything is done, he sends me the patient by saying him, this is a specialist in old age, and he'll counsel you and he'll treat your comorbidities and he'll counsel you regarding your further treatment if anything extra he needs to add. He just gives a small statement. And the screening is simple. The patient that my medical oncologist decides, only that patient I get. So there is no screening or there's no nothing else. The patient he thinks is appropriate for an assessment, he sends that to me. So what I've seen in my practice currently is that when these patients come to me, they are totally clueless. They don't know what what a geriatric oncology assessment is, how I'm adding to that. But that 30-minute assessment is like a two-way communication in that way. And these patients who have, now I have a data for around 35, 40 patients in the last 6 months. These patients just don't want to leave me now as a primary care physician. So the oncological aspect, they will definitely be going back to their oncologist, but their follow-ups regarding from head to toe, any symptom related to their, either mild ones like what you call grade 1 or grade 2 related oncology related issues, or maybe some other issues, whether there are inappropriate drugs or whether any drug interaction is there, or whether he had a fall, or whether he had a new event, or is it regarding nutrition, they will definitely follow up very regularly. And since the setup I work in is almost like Tata, and I think most major cancer centers are like that, where most patients that they get are from outside their the city of residence. So I think what I have seen is for follow-ups, telemedicine is extremely good to follow up them regularly.
Okay.
So I
So
have
I think so. What we'll come to the care model,
right,
but
right.
I understood what one is that domain related things you pick up and where you intervene. Second, do your oncologists change oncology related treatment based on your evaluation?
So as sir was saying, I think we should not focus on the changes that the oncologist
No,
is
I'm
making.
general asking. So
No,
domain is one domain.
not as of now.
And not as of
He will
now.
wait for the assessment to be there. But I have seen what their
No, no,
screening
no issue, no issue at
and
all.
eyeballing assessment
No,
is there. It almost correlates
no,
with the
no issue at all. No issue at
frailty
all. So that's
assessment.
eyeballing.
Yeah.
Because we'll come to Anant,
Right.
like what we people do,
Right.
and Dr. Vanita can say. So one is that domain-related issues, we do miss it. And what he's trying to say, domain-related people sitting, going through each domain and picking up that this domain requires intervention. We are not able to pick it with our eyeballing, and people do work on it. As far as the treatment of change of treatment is concerned, that is, we'll come back to about it. So,
Yeah. Hello, sir. So I'm coming from the clinical pharmacology background.
yes.
And so one of the things that we notice, or I notice here, is PIMs and the drug-drug interactions. So these are the primary focus from my end. And yes, sir.
So when you pick up those PIM, do you change drugs, and do the treating physician they change drugs?
I recommend it to the physician there.
What do they do?
That depends on the intensity of the problem.
So, what is the chance they change it?
It's
10%, 50%, 80%?
it's quite low.
It's quite low. Ananta, देखो, that is so all fault of Ananta, I'm telling you.
Not exactly.
Not exactly. Totally okay. So I think so. Again, idea is that so we oncologists many times I think so. Vikram left. So Vikram was right in saying we are usually in generally it is a human tendency. We are comfortable in a situation and we don't want to change because we have written something. जब तक साइड इफेक्ट हो नहीं रहा है पेशेंट को तब तक लगता है ठीक है विक्रम ने जो भी लिखा है वो अच्छी बात है बुक में है ये पेशेंट को तो हो नहीं रहा so I do agree that is not the best approach but that happens so I think so we need to you to work more on it maybe threaten them huh?
No, not that way. More like a collaborative approach.
Okay. So Anand, how does it benefit? What do you feel? Because now you have been there for quite some time working in this area. What you see perceptible difference when you evaluate and see that patient? What happens to them?
So whatever Akhil said, exactly the same thing. And as a clinician, it adds on to your assessment even when you're not assessing geriatric patients. That is the biggest takeaway for me. That eyeballing is out. Eyeballing is of limited use. Go deeper. Exactly what he said. That and the one thing that I'd like to add, and this I think you would have also seen in a lot of geriatric conferences, people complain about the lack of hard endpoints when doing comprehensive assessment. I think that's the wrong way to look at it. If you're improving quality of life, if you're escalating or de-escalating based on a rational assessment, I think those should be the endpoints. And that is what we can clearly see in our patients.
Correct.
That's what
we
we
will
can
come
see.
to that hard end point also. But this is important that more you do, these assessments and more you start seeing them, as Anand suggests, you start seeing that, you start managing them. And it happens very passively. It doesn't happen initially, but passively you start seeing that you start changing the way you manage them. Tarachand also been doing for geriatric oncology for quite some time.
Sir, as for the perception, yes, I am concur with Akhil that patient's quality life is much better, and after the reducing doses and calculating according to their geriatric models, and of course there is second part is also there. They are getting less admissions. That is getting their finances better to complete the treatment, and from our aspect, patients are coming far, like 200 kilometers, like Jodhpur and etc. And so that's they are need to come less time, and that's why they are saving their finance also. And after the geriatric, I'm looking another points also like polypharmacy and one more important thing, I'm having chakkar. Have you checked your eyes? Because just I look my eyes that 1.5 year back I was having frequent giddiness, but even I have to miss the I had to miss the meetings or on planned meetings because just my morning get up and I was having severe giddiness, but I am not able to even sit there. Then I was taking treatment of vestibular migraine and etc. When I meet my ophthalmologist friend, I told just for my daughter, yeah, I can see she is not able to see this. Well, please check your eyes for the near vision. And then I saw that it was 0.75 and this specs on my eyes, and now I'm able, there is no episode of giddiness. That's why he told me that after the age of 40, it comes to nearby everyone. So I ask every one of my patient of geriatric, please go for the refractory error checking. Yesterday only one patient was there. That patient is on TDXD on breast cancer, and he just complained me that patient is having drowsiness and giddiness, not able to move limbs and weakness, and that anything was there. But I saw that I am treating since last 1 year the TDXD, but I have never seen these things. Then I just saw the medicines which was being given by neurosurgeon for the back pain. That was gabapentin, admenta, that means momentamine, and prednisolone, etc. So I just look into the medicines and found that gabapentin is causing 20% of patients giddiness and drowsiness, and nortriptyline causing dryness of mouth and etc. So he was scared that he will not meet neurosurgeon, otherwise he will scold. Okay, I call him. Then I call, boss, please look into the matter. The patient is responding well to your medicines. Patient is having better pain relief, but the patient is experiencing the least side effect you mentioned in your medicines, but he is having biologically something different. That's why she is having these side effects. Please look into the matter if you can do it. So he removed that gabapentin anti. Now I will take the call what will happen on the Monday. These things are happening, but and I am sending all the patients to the dietitian. And yes, you send me one time a formula LCEF for head neck patient when I was in Sangrur, and I am giving to all my patients, make it with LCF, and I have tasted that formula also with soya milk, and this is tasty. Please, you can take it. So that's why those are getting improved nutrition and protein. One patient got 3 kg weight within 2 weeks. I am adding these formula. LCF you gave, no?
I remember.
You are not having patent right?
No patent right. I don't have anything on any patent right.
So I have circulating, and I am asking them to please grind these.
Will come to you.
I am asking please grind all these molecules, and you can buy from my shop also if you want these raw materials.
Yes.
And take a soya milk and mix it.
Yes, madam. You are saying something. Yes, yes, ma'am.
The LCM was done by us. I had done the study with your patient.
Huh.
So it was a low cost enteral formula.
Yes.
Only ma'am and myself have done that. So it is a formulation of cereals and millets which are there. Hydrated and given to, it's a low cost rather than the nutrition supplements.
Okay. Yes.
Especially the
Head and neck cancer patients. Yes.
had
Yeah.
done a study.
Yes. That's very true.
Now
And again,
I have changed little bit this. No? You are giving skimmed milk and sugar. I am giving soft soya milk of their flavor like kesar, pista, vanilla, whatever they want. And this is coming in 200. And I have used, that's why I know. I just tried what is the taste, so I am giving to the patients. And this is really fantastic in the taste.
so I'll tell you about Dr. Darachand. So it is always so wonderful to interact with him. So he's one of the many private practitioner. I interact with many people. That's a good thing about being an academic setup. So many private people, and then you realize that individual patient related detailing, which we miss. Unless others can say that they are able to do it, I miss that part. And that I get from so many. Every time I'll get some wonderful information from him, and what you heard, absolutely something like this I gave, this happened, then I change and say okay, then and you say whole longitudinal what happened to the patient detailing will be there. Absolutely wonderful, Tarachand. Always nice interacting with you. Rajiv, I know that you're working apart from ADR, now you're working in center where there is a good geriatric support. So what do you feel that how the patient benefits with what you are doing for geriatric patients?
So I
in
think
geriatric oncology?
I'll look at it from a different perspective. Like, geriatricians are usually a rarity. So I have been
Yes.
fortunate to work in a center where there are 12 geriatricians. So it's mainly a geriatrician-centered hospital. So that has made all the difference. Actually, the geriatricians bring in a lot of care and support for the patients who are the primary caregivers, and that has made my job as a medical oncologist much easier. After we, compared to Anant and Vanita, we are very junior in the geriatric oncology. This thing, but what I saw was, the patient preference is given a lot of importance because that comes with the geriatricians on close contact with the patient as well as the family. And then the clinical pharmacologist, which we have employed, we do listen to them, we change, and that has made a difference. My job is easier. I don't have to look at the errors very multiple times. And then the more importantly, the psycho-oncologist. So they get into the subtle, the family background, and there has been death in the family or road traffic accident. So we are given all these background inputs before we see the patient, and that has made the job much easier compared to I work in a non-geriatric oncology hospital where everything is in my head to go ahead and, from the consenting to the patient preference. And the patient preference, I think that was a sort of unlearning for people who are used to treating young patients. We make the decisions mostly in our mind before we see. When the patient denies something, then we are sort of frustrated and we sort of, unwillingly agree. But here, more and more we learn that that makes a better choice when we have a patient preference who absolutely don't want hair loss, no chemo, and then when we have options and we see the results, I think these are learning opportunities for us, and my job has been easier to work in a geriatric oncology unit.
Thank you. Annie?
Sir, it keeps people motivated and they get if I know about geriatric medicine, if I'm starting at my center, the other consultants will be aware about it. That's the most important thing that happens. Then when a kid comes to any clinic, they specially refer them to pediatrics. Unsaid rule. Like, ये तो बच्चा है, ये तो pediatrics के पास
Yes.
जाएगा. When an adult comes, that's okay. But when a geriatric patient comes, it's not like that.
It's not like that. As on
Everyone
date, it is
takes
not
care
been.
of that patient, and they don't have a borderlines that he's a geriatric patient, he has to be specially seen. Because I have two of my elderly parents at home, so I know how special they are and how different and difficult to manage them. So it's mainly the sensitization of whole department and whole hospital that they need in special care. That is most important. And once we do geriatric assessment, we talk to them for longer time, then we establish a connect and bond with them. So that even gets better from time to time. And obviously it will improve the comfort and quality of life of patient mostly.
So thank you. Prem, so Prem is geriatrician, so this is what he has done. How you feel like, how the patient, you say they come, refer to you, because you are able to see other side also. Oncologists, we are not able to see. Because we have got so ingrained into seeing कि tumor shrink हुआ कि नहीं. Other part, problem is that we have forgotten our hypertension and diabetes management also a whole lot of time, which when we got trained. But so what do you say? कि, hey, this part gets missed, and this is where you, contribute.
Yeah, I think, of course, first of all, it's extremely gratifying and satisfying because you actually, from both perspectives, because the patients know that you have given that time. And at the same time, we know that we have been able to make a difference purely because the quality of life is one of the most important things, if not the only important thing for the particular person. And we can say we as different specialities try to achieve that. So for example, you are trying to battle the tumor so that the person improves and has a better quality of life. But the thought process is for the tumor because you're an oncologist, because if the tumor is there and you are trying to take care of everything else, then that is not going to make you sleep in the night. But as a geriatrician helping you out, making your life easy, we obviously trying to help you to say maybe when you want to let go. Because a lot of times we are battling the tumor and we are not understanding that we have to stop battling the patient. I think shared decision making is something which is very important. Of course, again, very well talked about in almost every conference. And we always say in the Indian setting, it is always tough because sometimes it's the relative saying, I have not shared with the patient, how can you share? So then it obviously becomes more challenging.
But I feel ultimately it's, if like he was saying, I mean, there is different settings. So we'll come to the models. So the models have to be different. You have to be flexible in your thought process, how you will intertwine the joint sort of approach, wherein you want to make sure that yes, the cancer is taken care of, but you want to make sure that the non-oncological vulnerabilities are important, because ultimately, if a patient comes to you, you want to offer the highest level of care. And in this setting, if you have a specialist who takes care of above 60, and you are taking the organ, whether it's cardiology, nephrology, neurology, or oncology, you will ultimately give the highest level of care, and that is what matters to the patient.
No, no, thank you. Thank you so much. Dr. Babita,
Hello, I'm
your
a
end
medical oncologist working currently at NCI AIMS Jhajjar. So ours is a relatively new center, started in 2009 December, and it actually took off only after COVID. So we still don't have a lot of departments like clinical pharmacology or geriatrics at NCI. At AIMS New Delhi, it is there. So we have a real challenge to administer comprehensive geriatric assessment. So for now, what we are doing is like patients above 60 years of age, where we intend to give curative intent treatment and where we intend not to compromise doses, there we are administering CARG and CARG-BC. But the geriatric assessment is still not being done. We are hopeful as in the next phase, like we get more human resources and maybe we'll be able to start it properly.
I just today came to know there was an interview yesterday at AIMS, and hopefully you have some more geriatrician there to handle it. So go ahead, please. Go ahead. Huh.
While geriatric.
Correct.
But sometimes it has helped us in escalating the
I
treatment
agree.
as well.
I agree. Yes,
Yeah.
you feel eyeballing is different.
Correct. Correct. A 74-year gentleman, EGFR exon 19 del positive, P53 was also there. Initial thought was to give gefitinib alone. Patient was not feasible for osimertinib. But we did geriatric assessment. Patient was fit. We started chemo plus gefitinib regimen, which has been developed at our institute. So that is why it is not only de-escalating, it is also escalating.
I agree. We don't talk much about it, escalation part, because de-escalation at this moment is people look for. But I totally agree. Many times because many times our patients are those 40, 50 kg weight, and then you realize when you evaluate, they are absolutely very fit and they do all kind of things, and then you realize you can do a good job. Absolutely, right. One was which was pointed by Dr. Anant, that hard endpoints now started getting those kind of data, and that is something which people like to have it, and we should try to have it, and that's I think so. Our fault, or I'll say limitation of working in geriatric, domain and geriatric oncology, that we need to put those kind of research work and trial which have those kind of endpoints to show it. But that doesn't mean something is not visible, which is so apparent. And this I learned from one of my patient. She was again on osimertinib, exon 19 patient, elderly lady, and then she died. She survived for 6 years. Post-COVID, she made a specific point, and she had lots of weight loss and muscle loss after that, because COVID time she didn't move around much. And she said, "Doctor, you should have anticipated this." I said, "I agree, I didn't." Because she was restricted at home. But it should have come from you that I need to do exercise. And she could afford anything. I said, I could have got someone at home or online I could have done. But, because of not anticipating and not evaluating, because I had not evaluated that part. If it was evaluated by a geriatrician, I'm sure that would have been reflected, and then we could have integrated a service for her. So the learning was there, you require those evaluation. There was another lady, had a cough, lung cancer, cough, medial masses. Now, as much I knew, and I thought I know cough management fairly well, then I realized कि कोडिन के बाद तो समझ नहीं आता. आप cough syrup देते हो, फिर कोडिन syrup देते हो, and that lady used to read everything, and then I realized कि plain codeine is not available in India. Then dextromethorphan not available in India in the dose which is recommended, and I didn't know. She found out from Ahmedabad, somewhere the lozenges are available, and then she offered if you make a service, supportive care service in lung cancer, I will support it. I'll provide fund, but you guys are oncologists, you don't look after other part of the things, you miss it. So have a group of people only looking after it. And that was a telling thing, as much I take a pride that I manage well, but having said that, this is the good thing about patient, they keep showing you mirror. So, so absolutely agree, no doubt that evaluation, and now I see evaluation, in TMH, you have to have a look and then you get a hang of it, where the patient is. So, where the patient stands and what needs to be done. So this was how it benefits, and you hear from different people different things because they will have a different experience how their patients benefited. Coming back to care models, so we can go back to care models. Okay, doesn't look good. Okay, but anyway, ठीक है. So मैंने वो लैपटॉप पे अच्छा लग रहा था और someone can switch off the light on that side. Hopefully, it will make a look better. Huh? So, what do you practice and what do you think will be ideal? So, care model is either you have a geriatrician inbuilt into it, you have geriatrician who you refer to, it, or you have a screening tool, and then the patient goes for geriatric clinic. Anyone? Maybe we can start from so that because you will be establishing, so you have a chance to see which care model you will prefer.
Definitely, it has to be multidisciplinary with like all the stakeholders to be part of the team. So ideally, the geriatrician should be on board. So and each and every patient who is a potential candidate for comprehensive geriatric assessment, like maybe more than 60 or more than 65 as per institutional policy, should be assessed by the team comprehensively.
So idea is that screen and then do comprehensive geriatric assessment for all elderly cancer patients. Am I right? Okay. Prem?
I think...
but with the disclaimer, at this moment, you do Kargin. Correct? No? At this moment. But that should be ideally what she thinks that if that model is adopted, that will be most useful. So, Prem, what do you do today and what do you think that should be?
Yeah, so I think, having a geriatrician in the system would be very helpful. But again, a lot of times we keep thinking that no, everybody above 60 ideally should get it. Everybody, every cancer patient above 60. But a lot of times I think we have to pick and choose purely because the cancer patient has the thought process that I want the tumor to be treated. So do I need to see another person for it? Aap hi kyun nahi dekh lete? So it's a natural sort of thing which happens. So the oncologist role I think is very important. So like in the setting that I work in, I actually work in a daycare setting and also in a hospital setting. So hospital setting is purely like how it's a referral model, whereas daycare setting in a lot of times it is chemo is going on anyway. So we already know that the person I have been referred to, and then the oncologist is briefed that this is like how Karthik was saying, that this is a specialist for older person who will help us in knowing your non-oncological part so that we are able to treat you better. And people are obviously sort of convinced. Now, the most important part I feel is, which has been brought about already, is also sensitization. You cannot just tell the patient कि मतलब geriatrician है, जाना ही पड़ेगा. What is the cause? What is their need? What exactly they'll do? Because all those things I think matter a lot. And ultimately, multidisciplinary is important. Assessing is one thing. It's happening in Tata. It happens in a lot of other settings. Intervention is very important. There is no use of doing any assessment and not intervening. If the cognition is problematic, involve your therapist. If the physiotherapy is needed, everything has to go on simultaneously.
So what you're saying is at this moment, depending upon setup, in daycare you have one kind of setup, hospital you have different kind of setup. Ideally, you would have preferred that every 60-year-old should get an evaluation done. Anyone has a different opinion? Rajiv, same? Or from your center, all evaluation done or you do selected?
No, in the place I work for geriatric oncology, everybody has.
Everybody gets it. Absolutely. I heard,
And I think I will go one step ahead saying that only the screening and one-time visit may not help. The geriatrician should be part of the journey throughout. And more importantly, I think Gagan made a very important point. he was the only surgeon in the room and he has also left. So it's not only the medical oncologist who is part of geriatric oncology. It should be absolutely that, we should have a geriatric oncology MDT to start with our own peers attending, the surgical oncologist and radiation oncologist. And we are not able to do in one center. I think TMH can take a lead, and we have enough molecular MDTs now. Why not we have a national geriatric oncology MDT, and onboard online geriatricians at least, to decide on some cases will be of very useful.
Okay. Anyone, any other thing in mind? So it will be at this moment. Ideally, looks like everyone will like. It should be like pediatrics. The way Arnie was saying, the way you have less than 15, it needs to go to pediatrician or pediatric oncologist to see. Above 60 or above 65, whatever you choose, we choose above 60. Let all of them go to geriatrician, which is not there at this moment. Now you choose model based on where you are, unless anyone has any other ideas in mind.
I think one more point is we are trained for pediatric oncology, but we are not trained for geriatric oncology, at least
And that's why sensitization is not there, and that's why we don't send to geriatrician. So that is important. So good sensitization is important to have this working. Yes,
Sir, apart from oncology, it may also reduce all-cause mortality. If he is assessed by a geriatrician, maybe other things pop up that can get treated, they may feel even better.
Okay. So then,
Yeah, actually, because a lot of time the person does not necessarily die of the tumor.
I
Actually end up dying for
this is
about
like a
everything
prostate
else
cancer,
going.
CLL. You do have competing, risk is of dying for other things are pretty high. Maybe what are the challenges, Tarachan? So these are the models we say. What are the challenges in geriatric, evaluation, assessment, and implementation?
Sir,
Does your admin support it?
Yes,
As a
sir,
private setup, you have to think about admin supports or not.
Yes, sir. We are having admin support. Actually, we are starting fellowship in geriatric oncology also.
Excellent.
In my unit of geriatric. And second thing, the first resistance come from patient himself.
Oh, it's a patient
That
himself.
they don't have time. They want to rush to their home and etc. If we are evaluating, if I am evaluating a patient and I am talking to patient inside, or I am giving a time 20 minutes, 30 minutes sometimes. Just evaluating what is going on in at their home, what is the financial issue. Sometimes we check that we are having outside patients are just ready to fight and to beat me at that time. What is you are doing, doctor? We have to go home also, back. So please look at. And second thing, if we are sending them, please go to dietitian. Sir, he will charge another.
Okay.
And these things are quite, there is, if I ask my administration that please make a package for, especially I presented 2 years back a head and neck MDT in my tumor board that I need these 4 or 5 people on a board, that dentist, physio, speech swallowing therapist, physiotherapist, please make one fees only for these two. But it will be at least 1,000 rupees minimum charge if they are visiting for. So sometimes this is my patient, why are you charging 1,000, surgeon says, or sometimes patients are saying we are not started on any treatment and 1,000 rupees already paid. So these things are going on. These things are happening in community that are not happening on big centers, because where the patient usually come for any that I have come here and I will take the treatment, whatever is advised.
I get it. So I think so admin side, is not a problem as far as his center is concerned. Issue is how you implement it, because there's a cost involved and who pays for it. Anant, is the same problem here in TMH or is it different?
So I think we had covered this once before also. I think if you're offering a service, it has to be monetized, and patients will be willing to pay if you tell them the advantages. And since this is a 30 to 45 minute service that is being offered, I see no harm in doing that. Because after all, we are improving quality of life and potential tumor related things. And I'm sure corporate will not have a problem if you explain it in that many words. That's what I think.
Academic center?
We are doing it, sir. And we started with only, us doing the assessments. So, I mean, if you speak to a lot of people, if it is monetized and the patients are experiencing that this is part of service which is adding on to you, I don't think it will be a problem. That's what I feel.
So, yes, Akhil.
So the situation might be opposite for some patients. For some patients want comprehensive
Comprehend
care.
everything to you.
Because what we have seen, when 30% patients who were not referred to dietitian or physiotherapist, patients asked, please write dietitian.
Dietitian,
So
right.
that is very common with us. So I think now the patients demand comprehensive care, so it should be included.
So looks like it's picking up, and geriatric oncology as a service to the a patient. Sure, there are different challenges, different places, but concept has picked up. I was talking to someone कि कि ये वो मनमोहन सिंह की ये था, I think so speech as a finance minister. इसका idea आ गया है. Just the time for this idea is there, and so it will flourish. We all need to work on it, but it will flourish. Last 1 minute. Collaboration, how one can do in geriatric oncology. 10 seconds by everybody. One idea. How you can collaborate, people can work together, which is not easy in India.
Yeah,
It's
yeah.
not-
So geriatrician. So most centers do not have geriatrician. So
Okay.
for example, the good thing about TMH Varanasi is that TMH Varanasi is just next to BHU.
BHUs.
is the center of excellence for geriatrics. It is going to be the center of excellence that is under development.
बहुत बढ़िया.
Cross institute collaboration which are in the vicinity is important.
Thank you, Akhil. The way to collaborate with different centers and different group of people.
Geriatric,
One line.
Geriatric tumor board, sir.
Geriatric tumor board. Excellent. Yes,
I
ma'am.
think it's pretty well established in TMC here and what I've
Yes.
seen.
More
Pretty-
pharmacologists needed to be part of it.
Yes, that I
Yes,
agree.
I
and
totally
probably
agree.
most of the DMGs.
Yes. Anand, how to collaborate more between centers?
It's not enough to collaborate only with so-called academic centers.
Yes.
You need to collaborate with private centers. That's when it will gain this one. Otherwise, it will be restricted to 1 or 2 rooms and not go further.
Totally
That-
agree with
that
him.
is what we
And
need to
the
do.
word was so-called academic center. I totally agree. Yes.
Yes, sir. There is a need a collaboration with some NGO and some funding, at least initial years, where the people will get people want pediatricians separately. When will they realize that they are getting funded from outside or from NGO for that, like something fees like things?
Agreed.
And,
Totally
within
agree.
2 years,
The way
all will come back.
pediatrician has tapped the, absolutely wonderful. Tata Hospital Pediatric Group, generates almost 65 or 70 crores every year for the patient management. I think so. Geriatric, it's a good idea to sensitize the society.
I think I
How
agree
to collaborate more.
The academic and private sector
Both,
both
absolutely,
has
I
to join hands, and then maybe in 2-3 years down the line we will be in Hall A, and the lung cancer will be in Hall.
All be, yes. I agree. So it has been noted. Yes.
Sir, we
how
have to
collaborate.
persuade most of the people and we have to be persistent over it. Then only things will come.
And some people have to come together and be persistent.
and like
Keep-
can kids, we should get some other thing for us,
Yes.
for geriatrics.
Prem, one line, how to collaborate more.
I think the most important thing is to establish a pathway. You cannot expect people to just come to you because you want to get good care. So you have to have a proper structure to it. So I think structure matters. I'm going to quote you only. You had quoted something when we actually met in MOC, one of the inaugurations. You strongly believe that whatever is going to happen happen in the private sector. But I believe that with that, what has happened in academic, of course, has happened a lot. So partnership, yes, but partnership not only in the way of the academic sector doing the training and the private sector actually seeing patients. Academic is also seeing, but the fact that more and more private sectors are also part of education. I think that's very important because once you get the doctors more learned, I am very sure a lot of doctors also are warming up to it. So when they get the knowledge, I think it will be much better.
Correct. Yes. Don't quote that often. Huh? Babita is from AIMS. She will. I'm in academic center. They will outcast me. As much I believe that. In an academic center, especially government academic center. Academic center doesn't mean any academic center. Government academic center needs to pull up their socks if they want to make a difference. And in spite of me myself being an academic center, yes, I totally agree. Yeah.
So the collaboration has to be one at the institution level itself between the interdepartment collaboration. So for example, AIMS have an independent department of geriatrics and an independent department of medical oncology. So maybe if there is a rotation, it has to start from the beginning of the training. So if there is a rotation, like for example, medical oncology rotation in geriatrics for 6 months and vice versa. So that and more collaborative projects, for example, in terms of thesis, in terms of clinical trials, etc., to generate more data. Then at the inter-institutional level, especially the centers who don't have the facility, it can be like a hub and spoke model sort of can be employed, where the center that are already leading, they can guide the centers that don't have the facility and help them develop the facility so that more collaboration can take place in future.
Thank you. Thank you, everybody, unless there is some burning comment to make or burning question from audience. Yeah.
I mean, just to highlight the entire thing, to be very frank, when we started having these talks, I mean, we have been having the end of review and a lot of talks of, I think that itself shows that more and more people have been involved. I mean, and more geriatricians are available. So the fact that there is a lack of geriatrician is not there anymore. But it's the onus is also on the geriatricians to look for these sort of opportunities,
Yes, to
because I think
propagate
that is also very
also,
important.
yes. And in fact, now I think so. That's we were talking with Dr. Vanita. Now, most of the conference now has a geriatric workshop or a session, which used to be not there. If you take some time back, and so looks like it is picked up. People look towards that. This is one of those modality which needs to be integrated in the patient care. So. Sorry. A lunch is served. So that's a usual cliche that I'm between your lunch and you guys. So I'm not going to be now. Thank you so much. Thank you.